Greetings and welcome to this video on penicillins. In this video, we'll discuss about the physicians and critical care guide of the Penicillin G, Ampicillin, Amoxycillin, and the combination with Amoxicillin-Sulbactam and Ampicillin-Sulbactam drugs and its clinical usage. If you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. So, agents that we discuss in this video are Penicillin G, Ampicillin, Amoxicillin, and Ampicillin-Sulbactam combination. It is of great importance because it is one of the oldest beta-lactam drugs, but it is a definitive therapy for many infections even today. Because of its narrow spectrum and stewardship-friendly antibiotics, also it is a highly preferred drug. So mechanism of action, it inhibits the penicillin binding proteins, it blocks the transpeptidation, and it is also bactericidal drug, which is the most important property of this drug, and also time dependent killing. So the amount of time the drug remains in the body above the minimum inhibitory concentration, the more the bacteria is killed. So it destroys the cell wall. Frequency and infusion strategy is more important than the peak dose. So contraindications are mainly due to allergy. Penicillin drugs and the penicillin group of drugs are very notorious to cause allergic reactions. It can be either IgE mediated or can be severe delayed type 4 hypersensitivity reaction mediated. So if you have a type 4 hypersensitivity mediated reaction, you should never repeat this again. Penicillin group of drugs. So it can lead to Steven Johnson syndrome, toxic abdominal necrolysis, Dress syndrome, and interstitial nephritis. So IgE mediated reaction can be urticaria, angioedema, and anaphylaxis. In some people, this can be considered using again if in appropriate clinical settings. So many penicillin allergies are actually false. Delabeling them when possible has major stewardship impact. So it is now stated that more than 70% to 80% of the penicillin allergy indicators are actually false, and they are not actually allergic to penicillin. Maybe some small skin rash, they would call it penicillin allergy. So try to delabel them as penicillin allergy whenever possible. So, drug-drug interaction, it has few drug interactions with acid. It impairs renal tubular secretion, leading to increased penicillin levels. For allopurinol, there is increased risk of maculopapular rash with ampicillin and amoxicillin. So, ampicillin and amoxicillin should not be used with allopurinol, as well as should not be used for EBV-related sore throat, infectious mononucleosis, and can aggravate the maculopapular rash. So for amoxicillin specifically, in view of when using mycophenolate mofetil, there is decreased bioavailability, and again for antacids, this leads to decreased absorption of amoxicillin. So side effects of penicillin G, it is highly neurotoxic drug, can lead to seizure, confusion, myoclonus. It has dose-related toxic effect and highly pro-convulsant at high doses. Try to avoid this drug penicillin G whenever possible in case of a low threshold for seizures. So hematological or other conditions such as thrombocytopenia can occur with prolonged usage. Coombs positive hemolytic anemia can occur. Neutropenia can occur. Hypersensitivity and drug fever can happen. The skin, it can lead to maculopapular rash, especially with EBV infection, CLL, HIV, and allopurinol usage. Systemically, it can cause cytopenias, acute interstitial nephritis, hepatitis, and neurotoxicity in cases of renal failure. Cholestatic hepatitis can happen. There is higher risk. It is usually delayed, like 2 to 6 weeks after the intake of drug, and it is usually self-limiting. So amoxicillin, one of the uh, causative factor for cholestatic hepatitis. So it covers most of the organism of gram-positive coverage, such as streptococci, all groups, and penicillin-sensitive streptococcus pneumonia, Neisseria meningitis, and anaerobe such as Clostridium, Listeria monocytes, and Treponema pallidum, syphilis also. For syphilis and all, these are the drug of choice, but it misses the major drug, that is MSSA, which is penicillinase producer. So when you suspect an erysipelas with staph aureus suspicion, try to avoid penicillin. If you are suspecting only streptococcus, then it can be used. So definitive therapy of proven accessibility is there for streptococci, penicillin sensitive streptococcus pneumonia, Neisseria, and Clostridium perfringens, and syphilis is the drug of choice. So nowadays, ceftriaxone is now preferred for meningitis in case of Neisseria and Listeria and all, because of easier dosing compared to penicillin G. Penicillin G has extremely low minimum inhibitory concentration, so it is effective even at very low dosages. So historically, it is used for Streptococcus endocarditis, meningococcal disease, clostridial infection, and syphilis. Now it is predominantly gone out of favor because of the complex dosing guidelines and better availability of better drugs that are better tolerated and lower side adverse effects such as ceftriaxone. Ampicillin has a broader spectrum of coverage. It is similar efficacy for sensitive organisms. Theoretically, it selects more resistance compared to penicillin G. So ampicillin versus amoxicillin, these are almost have the same spectrum of coverage. It covers even Enterococcus faecalis, Streptococci, penicillin-sensitive Streptococcus pneumonia, and Listeria monocytes, but it again misses the MSSA organisms. So gram-negative and other infections, it almost misses every other organisms. So try to avoid this ampicillin amoxicillin for gram-negative organism because only 65% of E. coli is susceptible, 85% of protease is susceptible. Neisseria meningitis rarely and Lyme's disease also rarely. It is used with caution for all these drugs, not the primarily penicillin drug for these group of organisms. So clinical uses of ampicillin is for non-purulent cellulitis, pharyngitis, bacteremia, meningitis, and UTI. So nowadays, ampicillin is mainly used in case of Listeria, CNS infections, and Enterococcus faecalis if it is penicillin sensitive. It's also sensitive to E. coli and protease, but it is not the first line drug. For Listeria monocytes, it's even superior to Meropenem. Ampicillin-Tazobactam better than Enterococcus faecium. Now, with the addition of Sulbactam, it can cover MSSA and Streptococcus also. It's best for Klebsiella and protease, but the resistance is rising, so it's gone out of favor. Also has high anaerobes cover such as Bacteria fragilis in the combination of ampicillin and Sulbactam. Now, usage of ampicillin sulbactam is community acquired empyema, epiglottitis, oral and odontogenic infections, human and animal bites, and mild diabetic foot infections, Acinetobacter. In case of Acinetobacter pneumoniae, sulbactam is the active component and not the ampicillin component. So, dosing of penicillin G is in million units, so 12 to 24 million units per day when the GFR is more than 50. Adjust based on the renal GFR clearance. If it is less than 50, Q 6 hourly dosage. If it's less than 30, 8 hourly dosage. If less than 10, Q 12 hourly dosage. So high dose can lead to endocarditis and CNS toxicity. So it can give us 4 million units Q 4th hourly like that. So high seizure risk is there for penicillin G. Monitoring of the CNS and seizure threshold is being advised. Ampicillin, the standard 1 to 2 gram, pure fourth hourly is the uh, standard dosage guidelines. It is 2 grams, IVQ fourth hourly is the ideal dosage. For severe infections also, it's 2 gram IVQ fourth hourly. In case of low GFR, the dose can be modified, the frequency can be modified with Q 8 hourly or Q 12 hourly or Q 16 hourly. So for obesity, always use the upper limit of the GFR. So for ampicillin sulbactam, it is 3 gram Q6 hourly, of which 2 gram is ampicillin, 1 gram is sulbactam. So carbapenem resistant Acinetobacter baumannii, you can also use 9 grams of ampicillin sulbactam at Q8 hourly dosage, that is with a 4-hour infusion. That is the currently recommended protocol for carbapenem resistant Acinetobacter baumannii. That too, when it can be sensitive for ampicillin sulbactam only in that use cases. Or else you can go with polymyxin and sulbactam combination, which is better tolerated for carbapenem resistance Acinetobacter baumannii. So pharmacology, so it has penicillin G has almost 60% protein binding with low volume of distribution, excellent CNS penetration. Also can lead to seizure threshold, low seizure and because of its low seizure threshold. Amoxicillin has almost 80% oral binding and poor CSF penetration when compared to penicillin G. So final key takeaways are that penicillins are definitive. It breaks the cell wall. It's bactericidal drug. It is a not weak. It is a very good antibiotic, but it should be used in appropriate clinical setting. Used when susceptibility is known. Dose is given according to the site of infection, minimum millimeter concentration, and the renal function always. Always watch for neurotoxicity and delayed hepatitis in case of penicillin usage of penicillin group of drugs. So it has a good role in clinical stewardship because of very narrow spectrum of activity and very less resistance mechanisms. So it has a very good role in modern medicine and critical care stewardship. So these are taken from the IDSA, Sanford, and up-to-date standard guidelines. If you are new to this channel, do subscribe. If you like this video, do like and subscribe. Share it with your friends. This is Medicine Beyond Harrison's. We'll meet in yet another video. Thank you for watching.